Good morning and welcome to today's live COVID-19 panel with Doctors Jeanne Marrazzo and Paul Goepfert. Dr. Marrazzo is the chair of the Division of Infectious Diseases at UAB. Dr. Goepfert is the director of the Alabama Vaccine Research Clinic. For media that is joining us today, we will send a recording after the Q&A wraps up. And we're welcoming any questions from our public and our media. We'll start off with some key information from our hospital. UAB Hospital was caring for 183 COVID positive patients and an additional 20 COVID convalescent patients this past Friday. Our highest number of inpatients since we were caring for was 186 on January 13th. Based on internal projections, we anticipate our COVID census to fluctuate between 180 to 200 patients for much of this week. Today, we have 167 actively confirmed patients in-house with another 24 convalescent patients we are currently providing care for. Our infectious diseases physicians will begin with an overview of the current state of COVID-19 nationally and in our state, as well as the state of vaccines, and then take your questions. If you have a question, please submit them in the chat. Dr. Marrazzo, would you like to get us started?
Sure, happy to do a quick general update if you want me to do that, or did you want me to go right to the questions, Alicia?
Why don't you just give a quick update?
Sure. So I think everybody knows that we continue to see really dramatic expansion in numbers across the United States. We've reached actually record high hospitalizations, particularly for two groups of people that we haven't seen before, and those are people in their 30s and people under 18-year-olds, especially young children. We're also sadly seeing a fair number of pregnant women. At UAB, we've had around 14 pregnant women unvaccinated hospitalized, and we've had several deaths. I think you've seen some of the media around that. So the trend overall does not seem to be yielding across the country, but the Gulf states are pretty much continuing to be on fire. Alabama is number 4 in the country right now for number of cases per 100,000 people. And unfortunately, we're number 1 for the low rate of vaccination. About 36% of our citizens have been fully vaccinated, and we are actually ahead of Mississippi in that regard, which is a very unfortunate distinction, although I suppose it's good for Mississippi. So really, really unfortunate. You heard the numbers from Alicia about UAB. A couple of things that I've been pointing out, and I just want to emphasize that seem a little bit different about this Delta wave. And I should note that over 95% of the viruses that are sequenced at URB are now the Delta variant. So that's really what's doing this. We are seeing not only more people apparently getting transferred to the ICU with this variant. So of the 180 or so active cases that we have at UAB Hospital, over a third are in the ICU, about 60. About 50, and of those, the majority are on a ventilator. So this is a little bit different than what we saw before. Before, we tried pretty hard to keep people off ventilators. You may recall we used a lot of high flow oxygen. So overall, it looks like a much more challenging surge, obviously much more contagious, and very eager to hear the news about the FDA approval and what Dr. Goepfert thinks that's going to do for us in Alabama. So I'll stop there. I'm sure people have a lot of questions.
Thank you, Dr. Marrazzo. Dr. Goepfert, would you like to give an overview?
Well, I'll start with the FDA approval that Jeanne just mentioned, or Dr. Marrazzo just mentioned. It was approved today by the FDA, full approval. So that's our first COVID vaccine has received such approval. And I hope that the Moderna vaccine will receive such an approval as well later on this month, perhaps next month. It's hard to really predict what that means. It is great news because I think a lot of people have trusted the FDA in the past, and we're waiting for full FDA approval. To be honest, I think it'll mean a few, maybe 5 percentage points of the population will be moved in order to get vaccinated. But people can no longer say with a straight face that they won't take it because of lack of FDA approval. And this vaccine was, vetted extremely carefully by the FDA, and I think people should be very reassured that the vaccine is safe and effective with the data that were presented to the FDA and that the FDA took a lot of time to review. Just a little bit about the vaccine and the Delta variant. I know that this is the main concern of a lot of people now, is how does the vaccine stack up against the Delta variant? I think it's important to know that even though it doesn't work as well as against the original strain, it still works incredibly well. It may not protect so well against symptomatic infection, and in the MMWR that was highlighted by the White House last week, there are cases where you see decreased rates of protection against symptomatic infection against the Delta variant, anywhere from down to even 40% to 75%. And I think it depends on the population of individuals as well. However, what's impressive is that these vaccines are still working incredibly well to prevent severe disease in keeping people out of the hospital and keeping people from dying. And they retain 80+%, usually 90% in protecting against severe disease. So these vaccines are still incredibly effective. They're our best weapon against this disease. And remember, historically, vaccines are our best weapons against infectious diseases anyway. And with COVID, it continues that rule that this is an incredible vaccine that should be used by all. So should we go on to questions, or you want me to talk some more?
Thank you,
Alicia,
Dr.
could I just
Goepfert.
ask Paul, one thing? Because I have been asking people, both in our monoclonal antibody infusion clinic and on the wards, what are their major concerns against getting vaccinated? I think the FDA approval is a big thing, but the other thing that people have raised to me is sort of spiritual concerns related to the science behind the vaccine. And there is some sort of persistent rumor out there that fetal tissue is used for the vaccine development. Paul, could you comment on that? Because I do think that it's really important. People understand that when they're getting the monoclonal antibody, they're getting the same thing that the science developed, using the same techniques that resulted in the vaccine. So Paul, maybe you could just comment on that, if you don't mind.
Well, so in terms of testing vaccines in preclinical development, many of the vaccines and many products that we use in our day-to-day lives that aren't really being highlighted do use sort of fetal tissue because a lot of the cell lines that are used are fetal tissue, and they use them for development. In terms of the Pfizer vaccine, the Moderna vaccine specifically, though, none of the production now uses any fetal tissue. It's completely gone from that. And so when you get a vaccine, you don't get any fetal tissue whatsoever. And you are correct that the monoclonal antibody, even a lot of the drug treatments that we use have used that as well. So, I mean, it's difficult to sort of tease that out and to sort of say, well, it's just vaccines I'm not going to use, because there are many, many things that use that. And there are a lot of ethicists that have shown that it's okay to be doing this. It's not like people are taking these things. I mean, a lot of these fetal tissues were done a long, long time ago. Some of them were spontaneous abortions, things like that. I'm not going to get too much into that. Yep. But right now, the vaccines aren't using that at all. The mRNA vaccines don't use it. Fetal tissue at all in their production.
Thanks for clarifying that. Back to you, Alicia.
That's great information, Dr. Goepfert. So for our first question, I'm going to go to you, Dr. Marrazzo. Should we still be masking and social distancing? And if so, what is the recommendation for masking and distancing both outside and inside?
I would recommend masking and social distancing right now because of two main reasons. One is because we have such a low rate of vaccination in Alabama. That means we have a lot of uninfected people who are vulnerable to being infected and who then can infect other people. So if we were in a state that was incredibly highly vaccinated, where everybody was protected, I might be a little bit less likely to recommend that. The second reason is that the Delta virus is so contagious, so much more contagious than the original strains, that you need every added layer of protection you can get to avoid getting it. So especially if you're unvaccinated. And then the third reason is that we are seeing evidence of immunity from the initial round of vaccines starting to wane. And that's why the administration last week floated this idea of booster shots, which may start as soon as September 20th. That means if you are 8 months out from completing your vaccine series or your single J&J shot, you probably are experiencing a decline in protective antibodies. So you probably are vulnerable to getting the Delta infection.
That's great. And to that, can you talk a little bit about large gatherings, especially with the Delta surge and low vaccination rates? Is it safe for people to attend large gatherings? What about church, other ancillary type events, little league football games?
Again, it depends a lot on background vaccination coverage, how recently people were vaccinated, how likely they are to be immune. Remember, if you've had COVID, that probably protects you for a little while, but not in the long run. So you are very vulnerable to getting infected again, especially with the Delta variant. So I would say for large gatherings, you've really got to use your common sense. I personally, at this point in Alabama, would not feel comfortable attending large gatherings indoors. If it's outdoors, you've got to be really thoughtful as well. There have been now several sort of outbreaks of Delta variant associated with large outdoor events. In fact, there's some evidence coming out today that the Sturgis motorcycle rally, which happened just last month in South Dakota and gave rise to a big outbreak last year, may actually have done the same thing this year. So I think you've just got to be very cautious, especially if you have any reason to be concerned about getting Delta, given your underlying health.
And in terms of businesses, what recommendations would you give to a business owner? And with FDA approval, do you expect that we will see additional mandates for to show that you've been vaccinated from businesses and institutions?
Yeah, the challenge for business owners is that they don't know who's coming into their businesses, right? You don't know if they're vaccinated or not. And for that reason, I think it's very reasonable for business owners to require people to wear masks and even to think about limiting the number of people in a closed space if they have the luxury of doing that. Many people are trying really hard not to get economically hit again by this resurgence. And so they really do need people to come and patronize their businesses. So I think wearing a mask it makes perfect sense, unless of course, if you're eating or drinking. And if that's the case, then you've got to really think about social distancing and how vaccinated the room is. I do think with the FDA approval, we'll see more requirements for vaccination through employees.
Thank you, Dr. Marrazzo. Dr. Goepfert, with the FDA approval, there's a lot of questions about this approval, vaccine boosters, kind of what that looks like in terms of moving forward. Can you give us some additional information there?
Well, so the FDA approved the vaccine, so it's fully approved for individuals 16 years of age or older. And so I think the public should be very confident in vaccinating 16 years of age or older. 12 to 15 years of age can still be vaccinated under the emergency use authorization. I think it's important for providers not to start vaccinating children under 12 years of age. There's a couple of things with that. One is that they're studying that right now, and I suspect that they will in the next several weeks. There may be an emergency use authorization for that group, but the dose that they're studying is a lower dose. It's a 30 microgram dose in adults or 12 years of age and older. It's 10 micrograms in 5 years of age to 11 years of age. And under that, it's 3 micrograms. And so if you're going to now be giving the 30 microgram dose in younger kids, that could be dangerous. And I think that should be avoided at this point. In terms of boosters, I think the White House, along with Dr. Walensky at the CDC, Dr. Fauci, at the NIH, presented some very intriguing data that I think people should get boosted, and that's their case. However, the ACIP needs to sort of weigh in on this, and they did say that the ACIP and the FDA needs to weigh in on this, on whether a boost is needed or not. And so people right now, it's not, I don't think they should go out and get boosted until that whole process gets vetted. There are a lot of nuances in whether or not people should get the boost. As Dr. Marrazzo said, the immunity is waning, but this is antibody immunity, and this is antibody that's circulating. There's lots of immune cells in the body that are there for memory for long term that's likely going to last years. And that is likely going to protect against severe infection for a long time to come. And so if our goal is really to protect people from getting into the hospital and dying, then I think we may not need boosts. If our goal is to sort of decrease this Delta variant, which I think we don't want to underestimate, then maybe we do need boosts. But I think it's going to require a lot of people with different experiences along the lines of the FDA and the ACIP to weigh in on that. And that should come in the next few weeks before September 20th. And I think that they recommended the boost at 8 months, which would be sort of September 20th, when many people started getting their second dose back in January. And so you can see that it would sort of start off with healthcare workers and then people over 65, and then following the rest of the individuals as well.
Thank you, Dr. Goepfert. You've talked about a lot of populations, but let's talk about pregnant women. Is the vaccine safe for pregnant women? Is it showing to be effective in preventing severe disease for infants whose mothers were vaccinated while they were pregnant or breastfeeding?
So those are all good points. Every major medical society recommends that pregnant women receive this vaccine. While the studies were never done in pregnant women, they've vaccinated many pregnant women since then. And it's been shown in several reports to be safe in pregnant women. And we know for sure that women who are pregnant are at very high risk of developing severe COVID disease. UAB, I think last week, had close to 30 pregnant women in the hospital, 10 of whom were in the intensive care unit, and about half of them were intubated. None of those pregnant women had received a vaccine, or at least the full vaccination. And so I think the benefit far outweighs the risk for pregnant women. And I know personally there are a lot of OBs around the state who are advising against it, and that is absolutely wrong. Pregnant women should get this vaccine. And you mentioned their child. So obviously the vaccine is not recommended in children under 6 months of age, and it likely will never be recommended in children under 6 months of age. And the only way they're going to be protected from COVID is by getting that antibody from their mother. And obviously, if you vaccinate the mother, they will transfer their antibody through the placenta to their infant. And if they breastfeed, the same thing happens that way.
Thank you, Dr. Goepfert. Dr. Marrazzo, we're seeing high numbers in our hospital again. Can you talk a little bit about the treatments that are being offered in the hospital in terms of the ivermectin, Regeneron, monoclonal antibodies? What are we doing for those patients? And while we're looking at those patients, how many have had previous COVID infections?
Yeah, great questions. Paul may know the answer to the last question about how many have had previous COVID infections. I'm not aware we have that data at hand. It is something we really do want to look into. I can tell you that treatments remain very frustrating for many of us. We have very limited treatment modalities for a couple of reasons, and let me explain why. And I'll start with the monoclonal antibody. Regeneron is one of the monoclonal antibodies that we use to treat COVID. And just a reminder, what we're giving you when we give you the monoclonal antibody is the exact same antibody that we want your body to develop after a vaccine. So personally, again, you would like to have a vaccine-induced response rather than just getting the monoclonal antibody. Why? Monoclonal antibody, it's free to you, but it costs on average about $6,000 a dose. So it's very expensive. Number two, it requires extensive staffing. So there are limits to what we can do in our clinic to give people monoclonal antibody. You can give it as a subcutaneous injection. right under the skin. But what we have been doing and what most people have been doing is been giving it intravenously over the course of about a half an hour. You've got to watch people after that to make sure they do okay. So this is not like a one and done where you come in and get a shot, not even like the vaccine where you had to wait 15 minutes. It is a bit of an elaborate procedure right now. And there's very, very significant challenges about scaling up the capacity to do the kind of treatment with monoclonal antibodies that we really would need. I mean, for example, on Friday, we started our clinic at 7 in the morning and we saw 21 patients, throughout the day. Can't really do much more than that. So it's a great treatment. It really will help, but it is limited. And it's so limited that we've been telling people who are vaccinated who get COVID now to wait a couple days to see if they get better, because ideally they will not have a very severe episode, and we will not need to treat them with monoclonal antibody, and we can save it for somebody who might get into much worse trouble. So that's the story with monoclonal antibodies. The big challenge is that we have no oral pills to treat COVID, right? There are some studies right now that are being done, but we really don't have anything to offer people in the emergency department, in the clinic. We don't have anything. And ivermectin has been studied now in a couple of clinical trials. The biggest one was published in the Journal of the American Medical Association last April and showed very clearly that there is no benefit to at least preventing symptoms associated with COVID from worsening. It is being currently studied in a couple of clinical trials. So if you want to try ivermectin, please don't do it on your own. Don't go to the feed store, don't go to the vet store. It's a deworming agent for animals, and it can cause serious harm if you use it outside of supervision. So if you really want to try it, check out one of those clinical trials. We've been tweeting about those. We can get you those information. They're national studies and you can get into them. And then the last thing we got is remdesivir, which is a drug that was approved last year for COVID. That's used in the hospital, and we don't have an oral form of that yet. So all that to say, the monoclonal antibodies are great, but operationally severely limited in terms of our ability to get them to people. And then we desperately need safe, new, effective treatments for people who aren't sick enough to get in the hospital, but are at risk for getting sick.
Thank you, Dr. Marrazzo. All good information. Dr. Goepfert, we're getting a lot of questions on timing of the booster. So for example, I had my first shot in January, second vaccine in February. When should I get the booster? And a secondary to that is, if I get Delta, should I also get the booster? If so, when?
Okay, so I think we don't know any of those answers until the ACIP makes a recommendation on the boosters. But right now, the White House has recommended that the booster be given at 8 months after your primary series, so after your second dose. So you can make those calculations. And it's interesting. You shouldn't get a booster before that, frankly, because the immune system is interesting. It likes to have a rest between it. And there will be data coming out on a press release by another company tomorrow that will show that if you boost too early, it doesn't work so well. It's better if you wait. You get a better boost. So it'll be very important for people to listen to the ACIP and listen to the final recommendation, and not jump the gun in getting your boost too early, because you may be doing yourself a disservice. So there's the Delta virus. So the question is whether or not we need a specific vaccine for the Delta virus. And the answer is we don't know. I can tell you that companies are Pfizer, Moderna, they are all making it. Remember, part of the wonderful thing about mRNA technology is you can rapidly make the vaccine. That's why one of the reasons they were developed so rapidly is you can very, very rapidly make it. And they've already made a clinical grade Delta virus vaccine. However, it's not clear that we need it, because if you boost, you will boost very high levels that actually work against the Delta virus. And so right now, the recommendation is just to use the current vaccine that should work against the Delta virus following the boost.
Thank you. And can we talk a
I
little
was
bit?
just going to mention, excuse me, I was going to mention that the ACIP has announced the date of its meeting to review this, and it's August 30th and 31st. And those are open to the public. So you can tune in to listen to those if you want to. So just FYI, I think we'll probably hear something in very soon, maybe a week to 10 days.
Thanks. That's great information. I hope people will tune in and listen to that. Let's talk about immunocompromised, whether it's boosters, vaccines in general. Where do we stand on those that are immunocompromised, cancer patients, those with cystic fibrosis, or other health conditions? Do they need to get vaccinated? What are your recommendations?
Well, first of all, yes. So immunocompromised individuals obviously need to get vaccinated. The vaccine is not harmful in them in that there are some vaccines that immunocompromised individuals cannot get, but those are what are called live attenuated vaccines. This is not a live attenuated vaccine. The mRNA vaccines is just one little piece of genetic material, so it cannot replicate, it cannot cause COVID. And so they're extremely safe in immunocompromised individuals. And we know that immunocompromised individuals are at high risk of developing severe COVID were they to get infected. And so it's also now recommended that individuals who are immune compromised get 3 doses of the vaccine. So this is a little bit different than the boost, and you don't need to wait 8 months after your second dose. And it's probably going to be that you should probably do 0, 1, and 2 or 3 months out afterwards. So they should get 3 doses of the vaccine if you're immune compromised.
Interesting. Dr. Marrazzo, can you talk a little bit about herd immunity in terms of Delta? And, is there a peak for Delta? Is there herd immunity in relation to that? What should our target vaccination rate be now that we're seeing this new wave?
It's such a complicated question, and I probably am going to phone a friend, namely Dr. Goepfert, to make sure what I say is correct. But here's my take. Pre-Delta, we were pretty confident that if we got to maybe 70%, 75% vaccination coverage, like, for example, Vermont, that we would see enough protection such that sustained transmission in the community would not happen. Unfortunately, Delta happened not just with the mutations that I mentioned that allowed it to be more contagious, it also struck at the perfect time, in that the vaccine coverage wasn't as good as it should have been in many places, including our state. And also now immunity is waning from those first vaccines. So the answer is a really complicated mix of, how long have people been vaccinated? How immune are they? So how robust was the protection they got when they got the vaccine? And then, what's going on around them in the community. So I think that overall, everybody would feel a lot better about the potential for staving off additional mutants, like the next Delta. There is a Delta Plus, which is actually kind of scary, which thank God we haven't seen yet, but we may see. I think everybody would feel a lot better if our vaccination coverage was closer to 60% and ideally 70%, to make things look a little bit better for the future. But I'll let Dr. Goepfert reply.
So because of Delta, because it's so infectious, the threshold for herd immunity or community protection, as some people like to call it, is probably going to be 80 to 90%. And when you reach those levels, you're going to have to start vaccinating everyone, including children. So I don't think we're going to reach this until, even if all the adults decided to get vaccinated, which is already a sort of a possibly unattainable bar, the children will have to get vaccinated as well in order for us to reach it. And so, I mean, it's hard to know what the future holds. I think for the near term, COVID is going to be with us. The best protection you can do is to vaccinate yourself, because it will protect you very well, and it will decrease the rates of transmission. It's unlikely going to decrease it to 0, where we're not going to have any more COVID. But again, that is still a potential in the future. And when we get approval hopefully we will get approval for children 6 months of age and older, then we can really talk about community protection, herd immunity.
Thank you, Dr. Goepfert. We've hit our 30-minute mark. We're actually just a little bit over. So Dr. Marrazzo, do you have any closing remarks?
The only thing I would say is that I think Paul's comments about children are really important. When we were talking about herd immunity, we weren't really thinking about, little kids not only being really prone to getting sick from the virus, which unfortunately we're seeing now, but also being a major vector or reservoir of ongoing transmission. That's what we're seeing now. I think there's no question kids are going back to school, they're getting infected, they're bringing home to their previously vaccinated parents. And then that's where these infections are probably coming from. So I think probably even more than booster shots, as Dr. Goepfert said, the most important intervention we're going to be able to do in the coming months is to get an emergency use authorization for these vaccines in kids under 12 years old, and then hopefully to get that approved really quickly afterwards, because they're getting sick and they're transmitting the virus. So another reason that we really need to take care of each other and try to get everybody vaccinated as much as we can.
Thank you, Dr. Marrazzo. Dr. Goepfert, any closing remarks?
No, just stay safe. Please help us out in the medical community. We're really kind of struggling right now. Please get vaccinated. Please use masks. Please socially distance, because right now we're breaking records, bad kinds of records for Alabama. Highest numbers of cases in the hospital than we've had since the pandemic began. We will likely surpass that this week or next. So please do everything you can to help us out.
Hear, hear.
I know there's a lot of unanswered questions out there. We hear you. We see your questions. We're going to find additional opportunities for the public to engage with our experts and ask your questions. Dr. Goepfert, Dr. Marrazzo, thank you for your time. Thank you to everyone for attending. Our next panel will be on September 1st at noon with Drs. Jessica Grayson, Jody Dion, and Audra Williams, and they'll all focus on questions regarding COVID-19 and vaccines among women. To register, visit the UAB campus calendar. Again, thank you all for attending today.
Thank you.
Thank you. Bye-bye.